Good evening, everyone. Today we are going to explore a fascinating and under recognized clinical entity concurrent ipsilateral posterior and anterior semicircular canal benign paroxysmal positional vertigo. In other words, when free floating otoconia simultaneously displace to the posterior and anterior semicircular canal on the same side. At first glance, this diagnosis might look straightforward. After all, we routinely use the Dix-Hallpike test to provoke nystagmus and localize the offending canal. Posterior semicircular canal BPPV typically evokes an upbeating ipsitorsional positional nystagmus, while the anterior semicircular canal BPPV evokes a downbeating ipsitorsional positional nystagmus. Both are easily recognizable until they occur together on the same side. Here lies the diagnostic trap that forms the core of our discussion today. The potential for complete or incomplete masking of the vertical components during the standard Dix-Hallpike testing. Imagine two opposing vertical factors occurring simultaneously in the same plane of observation during the Dix-Hallpike testing. The upbeat vertical component from the right posterior semicircular canal, the downbeat vertical component from the right sided anterior semicircular canal. These two vertical forces can partially or completely cancel each other out. What remains may be a pure torsional nystagmus, a markedly diminished vertical component, or in the most deceptive cases, there is no nystagmus at all. The torsional element being the same direction for both canals when tested ipsilaterally continues to dominate and may lead the examiner to mislocalize the pathology to the central nervous system because a pure torsional nystagmus, either spontaneous or positional, is traditionally considered to be central in nature. The masking phenomenon explains number one, why many cases of the concurrent ipsilateral canalolithiasis of anterior and posterior semicircular canal are missed on initial testing, why patients may appear refractory to standard repositioning maneuver, and number three, why some clinicians have historically doubted the very existence of anterior semicircular canal BPPV. In the slides that follow, we examine the pathophysiology, the precise vector analysis, three video cases of the masked and unmasked nystagmus, and practical strategies to unmask the hidden vertical components so that we can accurately diagnose and treat this double canal variant without being fooled by the initial Dix-Hallpike testing. With this, I begin my presentation here. This is the case one. A 38-year-old female. 2 days back, vertigo began when the patient, while supine, transitioned to left lateral recumbent. Since then, transient vertigo occurs when the patient gets out of the bed, that is, from supine to sitting positioning, bends forward, and on transitioning to left lateral recumbent. Left Dix-Hallpike test after a latency of 7 seconds evokes a left torsional downbeating positional nystagmus lasting 30 seconds followed by left torsional upbeating positional nystagmus lasting 18 seconds. The video of the left Dix-Hallpike test is here. Initial 7-second latency is very apparent, and after that you see a left torsional slow crescendo decrescendo semel paroxysmal downbeat nystagmus. Now intermittently it is becoming paroxysmal. After 30 seconds it becomes left torsional upbeating and a typical crescendo decrescendo. So the direction reversal was there. The downbeat nystagmus becomes the upbeating, but the torsional component remains the towards the left. That is, the upper corner poles of both eyes were torsionally beating to the patient's left, whether it was downbeating initially or upbeating later on. We carried out a bow and lean test in this patient, leaning the head backwards around 45 degree evokes a few beats of right beating horizontal nystagmus. which is too inconsistent to be labeled as nystagmus, although a few horizontal beats to the right side are definitely present. Bowing the head 90 degrees forward evokes a right torsional downbeating bowing nystagmus. The torsional component becomes very apparent now as the upper corner poles are visible and they are torsionally beating to the patient's right. Why this happened would be clear as we go through the slides. We treated this patient with the right Apple maneuver and we examined the patient at 1 hour and after 24 hours. The patient was free of vertigo and there was complete disappearance of the oculomotor responses during the positional retest. Our diagnosis is concurrent ampullary arm posterior and anterior semicircular canalolithiasis co-occurring together. Why did the bone nystagmus was right torsional during the bowing? The otoconal debris, which is in the anterior canal, it remains same because the anterior canal remains almost horizontal during the bowing. The vertical canal otoconal debris, which is in the periampullary location, moves ampulopetally, resulting in the inhibitory deflection of the left posterior cupula, resulting in right dorsal downbeating bowing nystagmus. Diagnosis co-occurring left anterior and posterior semicircular canal BPPV. Clinical pearl in this case, the upbeat vertical component of left posterior semicircular canal BPPV partially masked the downbeat vertical component of left anterior semicircular canal BPPV. As a result, the positional nystagmus of left anterior semicircular canal BPPV was substantially weaker than that of left posterior semicircular canal BPPV. In fact, the nystagmus of left anterior semicircular canal BPPV look like the inhibitory nystagmus due to the right non-ampullary arm posterior semicircular canalolithiasis. Case 2, when we begin it, there is a publication of year 2000 from the Michael Fetter, and this is from the Journal of Neurology. A pure torsional nystagmus, either spontaneous or positional, is always caused by a central lesion, but we are going to prove this contrary. A 36-year-old female presented with 4 days history of vertigo on getting up from supine and on lateral recumbency to the right. The right Dix-Hallpike test shows right torsional positional nystagmus, no vertical components are seen. The nystagmus is short lasting 10 seconds as you can see right now and is pure torsional to the right. There are no vertical components. Period of observation of the nystagmus was around 40 seconds. Next, we carried out the enhanced straight hatching test. Cervical spine was maximally extended during the upright position and the trunk was thereafter positioned supine with head hanging maximally at the short edge of the examination table. In this position, after a short latency, we see a downbeating right torsional nystagmus. The torsional component, to our surprise, is very prominent, and there is in fact a small downbeat component as well. Somehow, when I see the downbeating torsional nystagmus, I always do a side lying test, and the side lying test to the right evoked a right torsional upbeating positional nystagmus of 20 seconds, which is typical crescendo decrescendo, suggestive of right posterior semicircular canal BPPV. These positional tests, that is the right Dix-Hallpike test, then the straight head hanging test, and the right side lying test that you see right now, were done in succession. Now at this moment we completed the right apply maneuver and we examined the patient after 1 hour, and at 24 hours the patient was asymptomatic and was not showing any oculomotor responses during the positional retest, that is the right Dix-Hallpike test, straight head hanging test, and right side lying test. What happened to this patient? The patient had a otoconal debris in the anterior canal in the periampular location. During the deep head hanging position, the otoconal debris reached the lowermost part of the right anterior semicircular canal, and as the patient was uprighted from the deep head hanging position, the otoconal debris it got dropped off into the utricular macula and got fixed. And that's how the right anterior canal BPPV was treated even during the positional test, that is the straight head hanging test. And when we did the right side lying test, that resulted in the pure right posterior semicircular canal BPPV nystagmus. The excitatory projections of the right posterior semicircular canal are to the right superior oblique and left inferior rectus that generates a slow phase VOR which is downbeating and left torsional. The positional nystagmus, which is a fast phase VOR, a reflexive saccade, is therefore upbeating and right torsional. In the right anterior semicircular canal, the excitatory projections are to the right superior rectus and left inferior oblique, generating a slow phase VOR which is upbeating and left torsional. Therefore, the positional nystagmus in right anterior semicircular canal BPPV is downbeating and right torsional because it is a fast phase VOR, a reflexive saccade. So, what happens when the posterior and anterior semicircular canal occur on the same side, say for the right in this case? The vertical components of the posterior semicircular canal BPPV may cancel out each other either partially or fully, while the torsional component of posterior and anterior semicircular canal they add up. The end result is that the vertical nystagmus vectors they cancelled out completely in this case, resulting in a strong torsional nystagmus because of the adding up of the torsional vectors of posterior and anterior semicircular canal which were on the right side. This is shown here by this diagram. Diagnosis co-occurring right anterior and posterior semicircular canal BPPV, shown by this animation here. The clinical pearl is that the upbeat vertical component of the right posterior semicircular canal BPPV completely masked the downbeat vertical component of right anterior semicircular canal BPPV. As a result, the positional nystagmus evoked during the initial right Dix-Hallpike test was pure torsional and mimicked a central pattern of nystagmus. Carrying out the straight head hanging test itself repositioned the otoconal debris from the right anterior canal to the utricular macula as we saw in that animated diagram. So what came next was the right side lying test that resulted in a typical nystagmus of right posterior semicircular canal, that is the right torsional upbeating nystagmus that we treated with the apply maneuver. Case 3 is an interesting female, a 50-year-old female. 5 days back, vertigo began in the patient while supine, and there was a considerable non-positional disequilibrium. Since then, transient vertigo occurs when the patient gets out of the bed, that is supine, so sitting, bends forward, and on transitioning to right lateral recumbent. The video summary of this patient: we started with the supine roll test, but at 45 degrees on head yaw to the right, we observed a downbeating nystagmus. First, supine positioning from sitting evoke few beats of right beating horizontal nystagmus like movements, not very consistent, but still in the setting of horizontal canal BPPV, I would take this as lying down nystagmus beating to the patient's left. On head yaw to the 45-degree to the right, which makes the right half Dix-Hallpike position, a downbeating typical crescendo decrescendo positional nystagmus was evoked. It suggested right anterior semicircular canal BPPV. Fading out now. It was a transient nystagmus lasting few seconds only. For persistent nystagmus, it has to be of more than 1 minute duration. Then we carried out the head yaw to the left around 45 degrees. This makes the left half Dix-Hallpike position. And there you see a very slow, tip, non-typical crescendo decrescendo, that is simul paroxysmal left torsional downbeat nystagmus. This nystagmus was fairly long lasting, and possibly it is an inhibitory nystagmus resulting from the ampulopetal movement of the debris in the right, not the left, posterior semicircular canal. The right Dix-Hallpike test shows an initial right torsional upbeating typical crescendo decrescendo positional nystagmus lasting less than a minute, and as this nystagmus ceases, there emerges a slow crescendo decrescendo simul paroxysmal left torsional downbeat nystagmus that you right now see on your screen. It appears that this patient has got two otoconal debris in the right posterior semicircular canal besides a debris in the right anterior semicircular canal periampullary location. In the posterior semicircular canal, it is in the ampullary as well as in the non-ampullary region. On uprighting the patient from the right Dix-Hallpike, we observe a downbeating left torsional reversal nystagmus. Carrying out the left Dix-Hallpike test evoked a slow crescendo decrescendo left torsional downbeating positional nystagmus of fairly long duration, and this definitely is because of canalolithiasis in the non-ampullary arm of the right posterior semicircular canal. And as expected, on uprighting the patient from the left Dix-Hallpike position, there was no reversal nystagmus. The nystagmus in the apogeotropic variant of the posterior semicircular canal BPPV, right in this case, do not reverse direction on uprighting. That is, there is no reversal nystagmus in these cases. Right applied maneuver was carried out 5 times. Positional retest 1 hour after the session of applied maneuver. The right Dix-Hallpike test during 1 minute observation in the right head hanging position did not evoke any nystagmus or positional vertigo. Left Dix-Hallpike retest was also carried out. The left head hanging position in the Dix-Hallpike test was maintained for 1 minute and no motor response of any kind was evoked during the period of observation. Patient was followed up 24 hours later also with the positional retest, namely right and left Dix-Hallpike testing, and there were no oculomotor evoked responses and the patient was free of vertigo. Diagnosis: co-occurring right anterior and posterior semicircular canal BPPV. The posterior semicircular canal BPPV was double clot BPPV with the otoconal debris in both ampullary as well as in the non-ampullary arm of the right posterior semicircular canal. Here it is shown by this diagram. This is the right Dix-Hallpike position test we are going to do here. The otoconal debris is here in the periampullary location in the right anterior semicircular canal, while in the right posterior semicircular canal, the otoconia are periampullary as well as in the non-ampullary region. So during the right Dix-Hallpike position, that is the step 1 of the apply maneuver, the otoconal debris from the periampullary locations of the right and left anterior semicircular canal, they move towards the lowermost part of the canal. Then the otoconia in the non-ampullary region of the right posterior semicircular canal, it reaches the lowermost position in the position 2 of the apply maneuver. When the nose is down, the otoconia they reach near the crus commune, and as the patient is uprighted from the nose down position, after 3 minutes, both otoconia from the ampullary as well as non-ampullary location are in the utricular macula. So that finishes my talk here. Thank you very much. The clinical pearl is that anterior semicircular canal BPPV is rare, comprising 1% of all known variants of BPPV. Performing a Dix-Hallpike test, as in case 1, or straight hat hanging test, as in case 2, can itself reposition the displaced otoconal debris in such cases. The apply maneuver itself can sometimes achieve effective repositioning, as we saw in the case 3. Thank you very much.